Good morning and welcome to all for our important session on cancer, which we are doing on the eve of World Cancer Day tomorrow. That's 4th. Sorry? Can I proceed?
Yes, ma'am.
Okay. A warm welcome to all of you for this important session on cancer, which we are holding on the eve of World Cancer Day, which is tomorrow, 4th of February. And today's webinar on cancer prevention, how far we have reached, is brought to you by the Kauvery group of hospitals under the Hindu Wellness series. Today we have an interesting panel of oncologists from the three departments, that is medical, surgical, and radiation departments, who will tell us how to fight this dreaded disease. We all fear the C word because we know that any cancer diagnosis has its roots in its killer nature. But with modern medicine, treatment options, timely treatment, awareness about lifestyle changes, we could help to scale all those fears. So to speak more about it in detail, I would first like to invite Dr. Suresh Kumar B. He is the medical oncologist from Kauvery Hospital in Chennai. He did his MD in internal medicine from Madurai Medical College and DM in medical oncology at Tata Memorial Center in Mumbai. His focused interest is in targeted therapy and immunotherapy. And he will first give a brief presentation on screening of cancers, prevention, and modifiable risk factors. A very warm welcome to you, Dr. Satish.
Thank you so much. So can I share my slides?
Yeah, please.
Good morning to one and all present here. It's very good to connect with you all on this platform on the occasion of World Cancer. So today I'll give an outline of cancer screening. So what do we know about cancer screening? So we know that cancer is one of the most common cause of death worldwide. Cancer is one of the most deadliest diseases, if not if cancer is, we can.
May I interrupt, doctor? Your voice is breaking.
Breaking? Am I clear now?
Yeah, could you try again?
Yeah. Am I clear now?
Yes.
Yeah. So if you look at the statistics, we can see from this image that about 14 lakh cases of cancer occur every year in India, and the numbers are rising. So every year the incidence of cancer is rising, and we can see from the image below that the 6 most common cancers include breast cancer, oral cancer, cervical cancer, lung cancer, stomach and colorectal cancer. In men, the most common cancers include oral and lung cancers, and in women, the most common cancer is breast and cervical cancer. So what do you mean by screening of cancers? So screening means detection of cancers before the onset of symptoms. So before somebody develops symptoms of cancers, we are diagnosing it at an early stage so that we can treat it much easier. So that is called screening of cancer. And so what do we do in screening? So it's basically a test. It can be either a blood test or an X-ray or a CT scan or an urine test. It's a small, easy test which can be done in normal people to diagnose cancer at an early stage. So even before someone develops signs and symptoms of cancer, we are trying to identify the cancer so that we can cure it. So I'm just simplifying something about screening about cancer. So if we look at a healthy individual, suppose if he's developing cancer at this point of time, it is at a very early stage. You can see, for example, a breast cancer, it is a small tumor in the breast. It is just growing. But apparently at this stage, patient is asymptomatic. That is, patient does not have any symptoms of cancer. He is completely fine. So if we catch the breast cancer at this stage, we can easily cure it by just doing a surgery. So at this stage, if we intervene, we can save the patient. We can cure the disease at a in a very easy manner. So this is called a preclinical phase where a patient is completely asymptomatic. That is, the patient does not have any symptoms. And if we diagnose the cancer at this stage, we can easily cure it. And this is the point at which the patient starts developing symptoms. That is, the tumor grows slowly, and patient starts to develop symptoms. And at this stage, if we diagnose, maybe it might be in an advanced stage, so we might not be able to cure the patient. And if we fail to treat even at this stage, it slowly spreads to other part of the body, and finally leading to death. So I'll just mainly focus about screening about a few important cancers alone. So we know that breast cancer is the most common cancer in India. So how do we screen for breast cancer? That is called clinical breast examination. That is, a doctor will touch and palpate the breast for any mass. So that is called a clinical breast examination. And the other important test is a mammogram. So mammogram is nothing but an X-ray, which is it's easily available everywhere, and it's also very easy to do. And it takes so examination. Mammography should be done. Mammography should be done after 40 years of age. Any women after 40 years of age should undergo mammography every year with a clinical breast examination. So every year they should see a doctor and get a breast examination done and a screening mammography. So if we do this mammography, we can diagnose cancers at a much earlier stage. Even before 2 years, we can discover it by touching it. So at a very early stage, even if it is before subclinical stage, we can diagnose breast cancer if you do annual screening mammography. And for people who are less than 40 years of age, they can do either clinical breast examination, that is, they can visit a doctor and get it done. But this is, I know this is very difficult going to a doctor every year. So what can they do at least is doing a self breast examination. That is, all the ladies can they can touch and feel the breast once in a while to see if any mass or lump is palpable in the breast. So that is about breast cancer. So all women 40 years of age should get a mammography every year to detect early breast cancer. And the next cancer is cervical cancer. This is also one of the most common cancer in women, and in fact, the most common cancer in rural women. So what is cervix? Cervix is the lower part of the uterus. So this region, which is the lower end of the uterus, is called cervix, and cancer arising from this region is the second most common cancer. So this can be easily diagnosed by a simple test called Pap smear test. So Pap smear, nothing is, it's we just take the fluid from the cervix and we examine it under the microscope. So by this test, we can easily diagnose cervical cancer at a very early stage, even at least 2 to 3 years before the patient develops cancer. We can find out the early stage of the disease. So when should we do Pap smear? So all women after 21 years of age should undergo Pap smear testing every 3 years up to 65 years of age. So this is a mandatory test for every woman after 30 years of age. They should undergo Pap smear test. So this is a very simple test. Anybody can approach a family doctor or nearby doctor and ask them for this simple test called Pap smear test. So next important cancer is colon cancer. So colon cancer usually begins like a small polyp, and this polyp will be there in the colon at least 5 to 10 years before a person develops colon cancer. So this polyp also can be easily diagnosed by using some screening test. So we have many screening modalities for colon cancers. We can, it is either colonoscopy or a CT scan or stool testing. So whom should we test for colon cancer? So the guidelines say that everyone after 50 years of age should undergo screening for colon cancer, either by a simple stool testing or colonoscopy. So since colonoscopy might not be easy for everybody, so at least a simple stool test can be done after 50 years of age every year for diagnosing or detecting colon cancer at an early stage. So next common cancer is lung cancer. So we know that lung cancer occurs mostly in smokers, and we don't have any guidelines or procedure for screening of lung cancers for everyone. So we mainly recommend screening for people who are heavy smokers. So that is if a patient, if somebody has smoked more than 30 pack years, that is if someone has smoked 1 pack of cigarette per day for 30 years, they are at a very high risk of developing lung cancer. And for them, we advise low dose CT scan every year, at least every 2 years to diagnose lung cancer. So that is about lung cancer. And the next common cancer is prostate cancer. So prostate cancer occurs in men, and it is one of the most common cancers in men. And prostate cancer can be easily detected by a test called prostate PSA, it's a prostate specific antigen. It is a simple blood test. It is widely available also. So anyone after 50 years of age can undergo this test to detect prostate cancer. So we know we have a screening tests for most of the cancers, and most of these cancers, by using these simple tests, we can detect at a very early stage, so that we can cure these cancers. Thank you, and happy to take any questions.
Yeah. So thank you very much, Dr. Suresh, for highlighting the importance of catching early and making use of the various screening tests that are available. We'll move on to our next speaker, Dr. Rajkumar S., who's the surgical oncologist with Kauvery Hospital in Salem. He did his MS in general surgery from Madras Medical College and with an MH in surgical oncology from Jawaharlal Institute of Postgraduate Medical Education and Research, Puducherry. His areas of expertise include breast conservative surgery, head and neck cancer resection and reconstruction, thyroid endocrine surgeries, musculoskeletal tumors, among others. And he will now present a brief talk on different types of cancers and their diagnosis, and also perhaps the availability of vaccines. So welcome, Dr. Rajkumar.
I will share my screen now. My screen is visible now?
Yes, yes, it is, doctor.
Yeah. Good morning, ma'am. On behalf of World Cancer Day, we are creating the awareness regarding cancer so that the cancer can be diagnosed at the early stage, or we can prevent the cancer so that we can reduce the incidence and thereby reducing the mortality and so on. So this is the cancer statistics in India. The most common, as we discussed earlier, the breast is the most common. The next one is the lip and cervix, lung, and colorectal, and so on. So the 5 most common cancers forms a majority. That is about 47%. Majority of them can be prevented by our lifestyle changes and avoiding the risk factors like that. And also these cancers and all can be screened and it can be detected at the early stage. But in current scenario, what we are seeing in clinical setting is, for example, for CA breast, only 29, that is 1/3 of the patient only coming at the very early stage. Majority of the patient coming in the loco-regional stage only. That is, the tumor has grown to such extent and it has spread to the nearby lymph nodes like that. This stage only, that is the local regional stage only, majority of patient is coming to the hospital for getting treatment. This should be taken care, and these patients should be shifted to the early stage or should be shifted to the screening population so that before the onset of symptom itself, we can identify them and we can cure them. So if we see the statistics worldwide, the first one, that is the Asia, it is contributing nearly just less than 50% of cancer burden. But if you see the mortality, it is more than 50%. Why means the incidence or we are diagnosing at little later stage. But Western countries, they are having the very strict screening programs and policies. So they are diagnosing at early stage, their mortality is less compared to incidence. We are little diagnosing at the advanced because the people, the patients coming to us at the later stage. So we have to understand what is the benign and malignant. The many people will ignore the symptom. If the patient, if the person develops any lump or swelling, they use themselves think that it is the benign swelling only. It won't be cancerous like that, and they will keep quiet and let their swelling to grow, and to a such extent it will cause some ulceration. Then only they will come to the doctor to get treatment. So if we see, this is the two lesions. First one is the benign one. Second one is the malignant. We can see the difference. The benign one will be very slow growing, or it may be static. But malignant one will have a very fast growth. Also, it won't stop with that. It will erode the adjacent structures. Like if it is forming under the skin, it will come out of the skin and it will cause ulcer, or sometimes it will go deep and it will cause the infiltration of the vessel, blood vessels or bone like that. It can involve. Also, it won't stop with that. It will spread. It will detach from the original site and it will go to the next place. So it will go to the adjacent place or lymph node. Sometimes even it goes to the lungs or liver like that. That is the what's the character of that malignancy. So only we are insisting to diagnose at the very early stage. As Saras discussed earlier, if we diagnose at the, if we identify by screening, the survival will be very much prolonged compared to the if we diagnose by symptoms. So screening means it should be done for normal individuals. So it's not for the patients. It is for normal individuals. If we screen the general public, general population, we may diagnose some tumors before the onset of symptoms. It will be very small, 0.3 centimeter, 0.2 centimeter like that. If we treat the disease, it will be completely curable, and duration of treatment, everything will be very short. We can use only one modality to treat the disease. Otherwise, we should use all the modalities like surgery, chemotherapy, radiotherapy, sometimes adjuvant hormone therapy, targeted therapy like that we have to use. As we have discussed some overlapping, for breast cancer, we have three modalities: self-breast examination and clinical examination. Next is the mammogram. Very in selected scenario or with a very high hereditary risk, we can go for MRI. These are all tests will be done in the first half of menstrual cycle. In the second half of menstrual cycle, usually it will be avoided because in second half of menstrual cycle, breast will be usually some engorgement will be there because of the progesterone effect. So these are the symptoms. Anything is the irregular shape, pimpling of skin, nodule, or nipple discharge. These are the symptoms of breast cancer. If there is anything is that on self-breast examination and clinical examination, they should be further evaluated. So these are the mammogram pictures, like simple X-ray. These are the technique of doing X-ray. X-ray mammogram. So many people used to think that if the mammogram is the radiation, that is a myth. Some will tell that frequent mammogram will cause some tumor in the breast like that. It is absolutely wrong. It's completely safe. It uses 0.1 centigrade. It's almost equal to the X-ray, the normal X-rays. So what is the advantage of screening means we can diagnose a tumor early. It can be completely cured. Sometimes we can preserve the organ. For breast, we can preserve the breast conservation therapy is possible, and very short duration of treatment. The very good thing is the better survival. We can get almost 99-100% survival, that is equal to the other people. So these are the symptoms we discussed. If we get a patient, if a patient comes with symptom, we go for mammogram and biopsy, and we do the complete checkup, PET scan or CT scan to rule out any disease spread beyond the breast. That is, it can be the liver or lung like that. Then we'll come to the conclusion that what is the stage of the disease. Then we have a multimodality, multidisciplinary discussion, and we'll go for the treatment in a sequence, whether surgery first or chemotherapy first, like that. We'll plan the treatment. So there is many ways to reduce the risk of cancer. The main thing is the reduction in obesity. The obesity causes increase production of estradiol hormone, which in turn respect for malignant breast cancer, and daily exercise. These are all as proven in many studies. Daily exercise, fruits and vegetables, and adequate breastfeeding, and avoiding the late first childbirth also it has some protective effect in prevention of breast cancer. So next most common malignancy in female is the gynecological cancer. It can either arise from the cervix or from the uterus itself or from the ovary. So if we take overall the gynec cancers, it's contribute about 15.4. The breast contribute about 20, nearly 25%. This we are seeing that the lower part tip of uterus, that is the cervix, that is the most common site. Due to multiple risk factors like early marriage and early first sexual intercourse or multiple partners, smoking, etc. The main thing is the HPV, human papilloma virus. It will cause a slow progression of disease. That's why the screening is very important. It will change a small change in pre-malignant condition. It will develop. It will take 15 years to develop malignancy. At any point of time, if we go, the person goes for screening test, we can identify that pre-malignant change or early disease, and we can revert back to the normal situation. So this is a pap smear. What is the impact of pap smear means even 70% of cancer incidence has been reduced by just following the pap smear in US. So we need a strict screening implementation policies. This is the recommendation. Every 3 years we have to go for pap smear. For 30 to 60, we can go for every 5 years if we do with the HPV. So same advantages. Another main important thing is the HPV vaccination. Now it's coming into the incorporating into the policies. HPV vaccination should be given at the age of 9 to 14 for girl child. There is only 2 doses, 1 shot, and 6 months after another 2 doses. The secondary target for this is if the child misses at before 14 years, we can give HPV vaccine as a 3 dose after 15 years. Even male child also has been targeted as a second target, so that they can avoid that penile cancer or the some benign genital warts kind of thing. Also, it will vaccination to the boys will prevent that transmission of virus to the counterparts in the future. These are the available vaccines that many vaccines are available. India also has preparing on vaccine that Servovac, that Serum Institute of India is preparing it to be available shortly. So if we diagnose a disease at the early stage, simple without removing the complete uterus, we can excise that part of disease alone. If we diagnose at the later stage, we need all modalities of treatment like this, surgery plus radiotherapy, or sometimes chemoradiation like that. So this is an important one, the survival. If we diagnose at early stage, localized means it's about 92%. If we diagnose at with the distant means the third row, it will drastically reduce to 18%. Now sometimes next common is the ovary neoplasm. Usually ovary neoplasm will be missed. What we see in clinical practice is patients comes with huge abdominal distension. They will think that it is obesity, like that. They will ignore the symptom. By doing simple ultrasound CT, there will be a huge ovarian cyst. So even though it's huge one, many times it may be benign, just a simple cyst. Sometimes it may be malignancy. We'll go with other tumor markers like that, and we'll treat them. According to the stage of the disease, the prognosis will vary. Even if it is whatever the large it is, if it is confined one, the survival will be very good, 93% at 5 years. Likewise, endometrial carcinoma, usually it will present with the post-menopausal bleeding. So the people who will come to the clinics at a very early stage, the prognosis is also very good. Usually these patients will present with that hypertension and diabetes with the comorbidity. So they will evaluation, they will have a thickened endometrium, and will do biopsy. After that, we'll go for surgery. Majority of the time, these patients can be treated with minimally invasive procedures like laparoscopy or robotic surgery. The survival is very good. The overall survival itself is 84%. In early stage, it is 96%. Apart from the survival and treatment, even if the patient gets malignancy, they get pregnant. These are many myths and doubts the patient will be having. In early stage, if they get diagnosed, after completing the treatment, they can go for the pregnancy. Induction programs are many. In treatment itself, we can preserve the fertility and they can go for pregnancy. The overall life birth rate will be up to 40%. Yeah. Thank you.
Thank you so much, Dr. Rajkumar, for explaining all these various aspects about the disease and why we should not ignore our symptoms. We now move on to our third speaker on the panel. He's Dr. B. Satish, radiation oncologist with Kauvery Hospital in Tennur, Trichy. He obtained his MBBS and MD from Jipmer, Puducherry. He specializes in pain and palliative care, conducting cancer awareness campaigns and screening programs, and also brachytherapy. He will now speak to us on factors, positive factors, and prevention of cancer. Most welcome, Dr. Satish. Yeah, over to you, Dr. Satish.
Yeah. The Hindu presentation. First slide. First slide. The presentation குள்ள போயிட்டு first slide. இதுக்கு முன்னாடி அப்படியே பேக் போங்க. Slides is not the first slide. Fine. Shall I start?
Yes, please.
A very good afternoon to one and all. At the outset, I'd like to thank the Hindu and Kauvery Hospital for giving me this opportunity to enlighten the people about oncology, radiation oncology, and what is latest about it. Since the prevention, screening, and aspects of cancer has already been very discussed by the other two consultants, I would be dealing about what is latest and how far have we reached in mitigating the side effects of cancer treatment, because that is one of the key areas which people dread every time they come to the hospital. They are always worried about the side effects of treatments like radiation. So I'm slightly digressing from the original theme, which is prevention of cancer, and I'd like to highlight the prevention of the adverse side effects of cancer with the contemporary and the latest advancements in cancer treatments. Myself being a radiation oncologist, I'll enlighten about what is latest and how far have we reached in mitigating and preventing the dreaded side effects of cancer treatment. Next. So the challenges to the oncologist today in 2023 is that the cancer occurs in anybody. It comes in any shape or size. It comes in any organ. It is surrounded by normal tissues. It spreads to the other organs if the treatment is delayed. And the cancer in the brain is not equal to the same in that when it comes in the mouth. So the cancer in each organ behaves differently. In each person, it behaves differently. And the treatment for cancer is also harmful to not only to the cancer tissue, but also to the normal organs. So these many challenges we have in treating cancer today. So what does radiotherapy do? Radiotherapy is the art of using ionizing radiation to destroy malignant tumors while being able to minimize the damage. I've highlighted the word minimize because we cannot totally negate the side effects of radiation therapy. But then in today's advancements, we can minimize it to the maximum extent so that the compliance of the patient is very good to treatment of cancer. Now, this is how radiation acts. Radiation acts at the DNA level and it destroys the DNA of the cancer cells and thus destroys the cancer. In other words, like when a surgeon uses a knife to throw out the lump or the tissue of that cancerous tissue, when a medical oncologist uses medicines that he infuses into the blood to destroy the cancer, a radiation oncologist uses ionizing radiation to target the cancer cells and the DNA and destroy the DNA, and that is how he tries to treat the cancer. Next. So what is high precision radiotherapy, which is currently the standard of care in most urban areas and not so in many of the tier 2 and tier 3 cities? So radiation has evolved over time. Initially, the radiation was given in two-dimensional fashion. As you can see that the silhouette of a man that is shown in the wooden block, assume that that is the cancer. In the olden days, maybe a couple of decades earlier, this cancer would have been treated with a square or a rectangular shaped radiation beams. So it is obvious that not only is that man being treated, but the surrounding tissue, that is the surrounding part of the wooden block, also gets a sizable amount of radiation. So that resulted in a lot of complications and side effects. So what happened was that a decade earlier or more than that, 3D conformal radiation therapy became standard of care, where we could shape the radiation beam according to the size and shape of the tumor and deliver it to the tumor. But still, we could not achieve a good outcome in terms of tumor control as well as the side effects, because we needed a differential dose of radiation to different parts of the tumor. So then came intensity modulated radiation therapy, or IMRT, where we can precisely sculpt the radiation doses. As you can see there, we can literally sculpt radiation dose as we need in today's era. Next. Now this is an example. Let us say this is a patient's brain and the red color tissue is the patient's tumor. Now in the olden days, this is how this patient would have been treated. This patient would have been irradiated, the whole skull would have received radiation, and consequently the patient would have had a lot of side effects, especially headache, raised intracranial tension, vomiting, and patient's decline in cognitive function. This was the situation a couple of decades earlier. Next. But it evolved, and we thought, why not irradiate only the tumor and the surrounding brain tissue? But as you can see, the surrounding brain tissue might be vital for various other functions of the body, like breathing, motor function, sensory function, etc. So that is also not very preferred, because that can also lead to a lot of side effects. So then came conformal radiation, where the radiation beam is shaped precisely so that the radiation beam is precisely delivered to where it is supposed to be delivered. So that was conformal radiation. But even then we couldn't achieve previously. Even then we couldn't achieve the required outcome. We couldn't achieve the outcome because not all areas within the tumor are the same. Some areas are hypoxic, which means their oxygen saturation is low, and some areas are well oxygenated. So when a tumor area lacks oxygen, then probably that region requires a higher dose of radiation, and probably some areas require lower dose of radiation. So the next cutting edge in radiation is try to modulate the intensity of radiation even within that tumor tissue to achieve an optimum response. Next. So this is an example. This is an image that is created with a radiation therapy linear accelerator. This is just to show that if you have to irradiate a tumor which is in the shape of a smiley, let's say, which means that a tumor can be of any shape and any dimension, we can still achieve the precise delivery of radiation with the current technology, which is intensity modulated radiation therapy. As you can see that this smiley has been irradiated precisely in the shape of a smiley. Next. Now, what is cutting edge in radiation oncology? We have moved on from 2-dimension to 3-dimension to 4-dimension. And in 4 dimensions, we have moved on from 3D CRT, IMRT, VMAT, IGRT. These are all various latest techniques. It will be beyond the scope of this presentation to discuss in detail about each of these techniques. And from SBRT and SRS, today we have reached up to proton therapy. So why is all this advancement? What is the use of all these advancements? The basic problem is that we try to reduce and mitigate the side effects of cancer treatment. We want our patients to come to the hospital and go out of the hospital happily without being crippled by the treatment and its side effects. Next. Now, this is an image taken from the Chernobyl nuclear accident. People always, they allude to nuclear accidents like Hiroshima, Nagasaki, Chernobyl and all that, and they always fear radiation therapy. Of course, that is a sudden exposure of high dose of radiation. As you can see that person there in the bed has been totally desquamated. His skin has been totally peeled off with extremely high dose of radiation. So that is why we fractionate radiation. Radiation therapy, unlike surgery, is not done in a single day. It is fractionated over a period of 25 to 30 days. so that these patients do not suffer the toxic effects of radiation. And if we, for example, if a spinal cord is irradiated in the same day with a high dose, we might actually, the patient might actually land up in paralysis. So radiation therapy is usually not given in a single day. It is fractionated over a period of days. Now we'll briefly touch upon how we are able to achieve this kind of a high dose radiation treatment precisely to the tumor, but not affecting the patient too much with side effects. So a patient's contour is usually taken with a plastic mask like this. Next. And this patient's CT scan is taken with a mask in place, so that, for example, in this patient, let's say this patient has an oral cavity cancer and we need to irradiate the tumor. We need to precisely irradiate the tumor, so we make sure that the patient is immobilized, so that so that this patient, next, that one, yeah, so that the patient does not have to suffer the side effects of radiation. So we immobilize the patient with a thermoplastic mask. Next. So next we take a CT scan, next, like this, next. And after CT scan, we draw the patient's tumor on the CT slices. Every slice we draw, so that this patient previously, don't change without anything. Previously, precisely, we are drawing it slice by slice, the tumor as well as the surrounding normal tissues, so that we'll target the tumor precisely. Next. And then we, with the help of medical physicists, we place the radiation beams in different directions and adjust the various physical parameters and technical parameters, which is again not very relevant to today's talk. Next. Now this is a case of cervical cancer, which in the ancient days, in a couple of decades earlier, this is how we would have treated a cervical cancer. As you can see, a rectangular field is being planned, and so whatever is there within that rectangle is going to receive radiation. And so not only the cervix and the uterus, but also a lot of bowels, large bowels, small bowels, bladder, rectum, everything is going to receive radiation. So hence these patients get a lot of side effects. They used to get a lot of side effects, and that is why they feared the treatment of radiation. Next. But today we could precisely draw and contour the regions that require very high dose of radiation. As you can see that those regions that are there in orange color require high dose of radiation. Those that are there in blue color probably do not require high dose of radiation. So we can sculpt the radiation dose precisely where it is required in higher doses and where it is not. Next. So we can also visualize all the organs of the patients in 3 dimensions, the bladder, the target, that is the tumor, and the rectum. And we can plan brachytherapy and radiation therapy, so that the delivery of radiation dose is exactly to the tumor, but not much to the other organs. Next. Now this we can achieve with the help of a multi-leaf collimator, which will help us in achieving this advanced treatment. Next. Now, what is the advantage of this cutting edge intensity modulated arc therapy or radiation therapy? Next. It is an outpatient procedure. The patient does not have to get admitted to the hospital. It provides better cosmesis because with radiation, we preserve the organ. So the patient can achieve a better cosmesis. And as I said earlier, if a patient has a laryngeal cancer or a vocal cord cancer, then if a patient has to opt for surgery, then that organ has to be removed from the body. Whereas with radiation therapy, the organ can be preserved and the patient's voice can be restored. And at the end of treatment, the patient preserves the vocal cords, he gets back his voice, and he does all this with very minimal side effects. Next. And radiation therapy can reach surgically inaccessible sites, like as I've shown earlier, a critical brain tumor, a critically located brain tumor, or an acoustic neuroma, a location which is so critical that a surgeon cannot access. It can still be accessed with radiation, and it can still be treated with a high dose of radiation while mitigating the side effects. As I said, radiation is sutureless and painless. Yeah. And a last slide about particle beam radiation, which is currently the sensational thing in radiation oncology. You would have heard about proton therapy, which people are discussing everywhere. While proton therapy is not widely available across the world, it is available in selected centers. These particulate radiation are even more advanced because they also deliver a radiation dose without penetrating through and through to the body. For example, in this patient, as you can see, the red area is a tumor and an electron beam was used to treat this patient. This radiation deposition has been precisely stopped, let's say, at 2 to 3 centimeters from the patient's skin. And what lies below the red color area is the patient's spinal cord. As you can see that there is not even a low dose radiation that is deposited in the patient's spinal cord. So superficial tumors or tumors beyond which there are critical organs which you need to save critically can now be treated with much more precision with particulate radiation like electrons and protons. So to conclude, in cancer, overdose is toxic. Of course, it was toxic. And of course, the treatment of cancer was very unbearable in the olden days. But at the same time, you cannot underdose the cancer because that can cause very dangerous side effects. The tumor can recur, it can spread to other organs. So the oncologists are always in a dilemma whether to increase the dose and result in toxic side effects for the patient, or decrease the dose and risk the cancer recurring or spreading to other organs. This dilemma has always been challenging for the cancer specialists. So what we had to do, we have to escalate the dose to the right level so that the toxicity is also minimized. We have to prevent the dreaded side effects of treatment. With advanced radiotherapy in the form of intensity modulation, arc therapy, and protons, it is possible to treat a patient with a high dose of radiation while minimizing and mitigating the side effects to the barest minimum. So that is how far we have reached in technological advancements in the treatment of cancer. Thank you for this opportunity. Thank you.
Thank you, Dr. Satish, for those valuable inputs and telling us how to mitigate side effects. I would also like our participants to start sending their questions. And meanwhile, I would like to ask all the 3 doctors on the panel, all your slides had one common thing about when we were talking about statistics, that there are certain kind of cancers which are more common in men and certain are more common in women. So is there any particular reason for that? And if we already know that these kind of cancers are common in men or women, what exactly can be done, or can really anything be done to prevent them? I mean, what is the reason that certain cancers are common in men and certain are common in women first?
Yeah.
All of you could give your inputs.
Yeah, so first is the organ. If you look at the organs, some organs are there in the men, some organs are not there in the women. So
no, I mean the general, even the general cancers, not just the specific organs. Yeah.
Yes, it's mainly because of hormonal issues. So estrogen and progesterone are there in the women. They increase the risk of certain cancers, whereas decrease the risk of certain other cancers. So men, we don't have estrogen and progesterone, we have testosterone. So the risk of cancers differs based on which hormone is there. So that is the main reason. Apart from there are other environmental factors also, which are common to both. So that influenced by the hormonal factors which increase the risk of cancers. So that is one thing. And second is occupation also. So men usually go to workplace, they get exposed to more amount of pollutants, chemicals, etc. So that might also be a risk for more cancers in men.
Would you like to add something, Dr. Satish?
Yeah, if you see the statistics that describe about the causative factors of cancer, if you could point out the singular most important risk factor for cancer, then it is smoking and of course alcoholism. In a country like India, still women are not exposed to such habits largely, and still Indian women don't smoke or drink to a large extent. Of course, in the urban areas, that trend is changing, but Indian men are exposed to tobacco and tobacco related products in much more numbers than the Indian women. So that is one prime reason why oral cancers and lung cancer is predominant in developing countries, because our men are exposed to smoking and alcoholism in a much more the exposure is much more compared to women. So that is one reason why men are exposed. Men get more cancers than women. As the doctor correctly said, as Dr. Suresh said, women usually get cancers related to hormonal imbalance, like an endometrial cancer, an ovarian cancer, or a breast cancer. due to menstrual irregularities and stuff like that. But usually men, and of course men with unsafe sexual practices, that is also quite rampant in some areas. And these are the main risk factors why men are getting more cancers than women.
Right. Do you want to add something, Dr. Kumar?
Yes. Previously, if we take women, previously the cervical cancer was the first topmost incidence level. Now, because of westernization, our culture has changed towards westernization. The high-caloric diet and obesity and sedentary life and late marriage and late first childbirth, these are all relating to increase in the breast cancer now. Also, we are seeing that the early menarche and late menopause, these are all the risk factors considered as the breast cancer. The main thing is the estrogen exposure. That is the main road for the development of carcinoma.
As we all understand, cancer in early stages is asymptomatic. And in our Indian households, we normally don't go to a doctor or a hospital till we fall ill. So what do you do to, kind of really drill it inside people that we really need to have these screenings done, even when, as one of you said, that even if we are not ill, even a normal individual needs to do these screenings. How can we, kind of bridge that gap?
Yeah, so first is there is a stigma associated with the diagnosis of cancer. So many of them get feared of just the diagnosis itself, and because of that, they don't go to the doctor even if they have some problem like a mass in the breast, a lump in the breast. They don't want to go to a doctor because they tend to hide it from the family and the society, because they don't want to others to know that they have the cancer. So that is the first thing. Apart from that, if we see next is availability of healthcare also may play a role in rural areas, where as of now the healthcare access is increasing, but there might be some areas where they may not be able to access the healthcare, but that is not the case right now. It is slowly improving. So, and third is awareness. So, mainly increase awareness about the people, about the common symptoms of cancer, common methods available for preventing the cancers, and what are the screening tests available for cancer. So, if we mainly improve the awareness, then maybe we can prevent cancers as well as catch cancers at an early stage.
Right. I think actually a lot of questions have started coming in, and I'll start straight away dig into it. Somebody wants to know that our fat patches, are they cancerous? Can they be cancerous?
Fat patches are called the lipomas. They are benign tumors. They are non-cancerous.
Okay.
They don't spread.
Okay. Deva Gopal is asking that cancers caused by external and environmental factors are probably preventable, but cancers caused by genetic predisposition and autoimmune condition, are they preventable?
Instead of saying preventable, we can be little more cautious. Nowadays, we can get genetic tests done. When a patient has a strong family history of malignancy, then there are a battery of genetic tests that are available currently, which the patient's relatives can give us a blood sample and get themselves tested for genetic abnormalities. And if they harbor the cancer causing mutation in their genes, then they can get into a screening program which is customized to their own problem. Like as we said, in general, if a breast cancer screening starts at 40 years of age for the general population, for a patient with a BRCA mutation or a cancer causing mutation because there is a family history, then we start screening earlier than what is recommended for the general population, as we usually start screening from 25 years of age, and we'll try to identify the cancer as early as possible and cure the patient. So the answer is, like, we cannot prevent genetic cancer, but then we can identify those who are at risk earlier, and you can advise them to get into a structured screening program so that we try to diagnose it early and treat it early.
To add some more points.
I do agree, but there is maybe a small a proportion of cancers inherited which can be prevented. Example, if you take breast cancers, if you know multiple family members are having breast cancers, you check yourself, and if you also have that particular cancer causing mutation, you can go and do prophylactic surgery. Like if you take the case of Angelina Jolie, she had a high risk for breast cancer, and so she had both her breasts removed to prevent her risk of developing breast cancer. So like that, for patients with high risk of ovarian cancers, maybe they can go and there are some programs where you can oophorectomy, where we remove the ovaries to reduce the risk of cancers. But this applies only to a very small group of people.
So since we're talking about breast cancer, Ramesh Kumar is asking that what is the main carcinogen responsible for breast cancer, and do unmarried individuals also get breast cancer, and whether it can be prevented by lifestyle change or food habits?
Carcinogen, this main respect is the estrogen. That estrogen plays the main role for breast carcinogenesis. Unmarried has a high risk for developing breast cancer, because if they get pregnancy, so the pregnancy, the estrogen will disappear. The progesterone, only the dominant hormone throughout the pregnancy and during the lactation. So only the lactation also insisted for minimum 6 months. So for 1.5 years, they will be off from the estrogen. So it considers a protective factor. Also regarding lifestyle changes, daily exercise, the minimum 30 minutes of exercise per day, it's considered as reducing the cancer incidence overall. Or if you take breast, colorectal, everything it reduces the incidence of cancer. On food wise, it's now we are consuming a lot of adulterated food. The natural foods, that green leaf vegetables, many fruits and all, it's considered protective. High calorie diet, junk foods, fast foods may increase the risk of tumor.
I'll go back to the first question about fat patches. So you mentioned that it's usually not cancerous. I want to know whether it can turn cancerous, and how frequently should one get checked? And is it compulsory to remove the lipomas, or is it just done for a cosmetic purpose? Dr. Suresh.
Yeah. Lipomas, you mean that the lipomas?
Lipomas, sorry, lipomas.
Lipomas. That's a fat swelling. If it is larger size, if it is disturbing our daily routine activities, or if it is cosmetically disfiguring, it can go into surgery. Otherwise, it's very less likely to turn into malignancy. Otherwise, if it goes more than 5 centimeters, then we should go with biopsy. We have to do biopsy and confirm that it is a non-cancerous. Then we can leave it.
Okay. Dr. Satish, from your slide presentation, Deva Gopal wants to know the 3D or 4D sculpted radiation therapy obviously requires high precision imaging of the tumor cells and the surrounding tissues. So he's asking, are imaging techniques keeping pace with the advancement in therapeutic approaches?
Thank you for that wonderful question. The tumor volumes have also evolved over the period of time. Initially, as I have shown in my slides, initially it used to be just a rectangle, and whatever is there within that rectangle used to get radiation. Now, after that, that was an X-ray that I showed. Then from X-ray, we moved on to a CT, which gave a better image quality, and we could precisely contour the tumor as well as the organ from which it arises. And then from the other, we could also contour the normal organs and spare them from the ill effects of radiation. From there, we moved on to a fusion of an MRI with a CT, because just not a CT, we also have an MRI to help us to even more precisely delineate, as in the case of brachytherapy in cervical cancer, an MRI guided tumor volume definition has evolved, because we use the precise image characteristics of an MRI to precisely deliver radiation. And from there, we have moved on to a PET scan based target volume delineation, which we call as a metabolic target volume. What we see in a CT or an MRI is just a morphological description or a morphology of the tumor. We see the tumor size, shape, and all that. Whereas in a PET scan, we see something more than that. We see the metabolic activity of the tumor, and in which areas is the tumor highly metabolically active, and in which areas it is not so highly metabolically active. And based on that information, we can still tailor the radiation, as I've shown there, like a smiley. We can tailor the radiation beam to deliver more dose of radiation where it is required and less dose of radiation where it is not so required, even within the tumor. So we have evolved in our image characteristics also from an X-ray to a CT to an MRI to now with a PET scan. We use PET scans to treat tumors that require precise radiation.
So it is possible to access tumors for radiation exposure if they are really deep under thick layers of bones and muscles, as somebody is inquiring.
Yeah. The radiation that we use to treat patients is gamma rays, or it is electromagnetic radiation. And this electromagnetic radiation has the unique characteristic of penetrating deeper. In fact, we have actually started moving away from that characteristic aspect of gamma rays, because initially the cobalt machines which used to treat cancer patients were treating with gamma rays, and these gamma rays used to penetrate so deep that it used to come through and through the body. So that resulted in a lot of toxicity. So now with the latest advancements in radiation therapy, like electrons and protons, we try to find out better ways to limit this penetrating capability of radiation. We try to just customize radiation in such a way that it penetrates only till where we say that this is where you should stop penetrating. And that is the advantage of protons and electrons, where we can precisely say like a tennis ball on a sand or something. When you just drop the ball just stands there. So that kind of precise radiation was not available earlier. When you pass radiation like a torchlight through a paper, it used to come through the other side. Now with particulate radiation therapy, we can precisely prescribe where we need the radiation to stop penetrating.
Satish Kumar Sabapati wants to know whether there are molecule markers available for early detection of all types of cancers. Dr. Suresh, would you like to take that? You're not audible. You have to unmute. Unmute.
Yeah, we don't have any such molecular markers, single molecular markers where we can diagnose all cancers. We only have screening tests or other diagnostic tests which we can diagnose.
Sakina wants to know, can fibrosis in breast cause cancer? Fibrosis in breast, can it cause cancer?
I will take it. The fibrosis, usually in menstruating females, there will be cyclical changes. It's called fibroadenosis, or sometimes it's called as defined number is fibroadenoma. Both never turn into malignancy. No need to worry. Fibroadenosis will settle by own after menopause. Fibroadenoma, it will also regress. If it is large only, then they need surgery. Otherwise, no worry about malignancy.
Dr. Suresh, in your presentation, you mentioned about this cervical cancer being more common in rural women, and the compulsory mandatory pap smear test that needs to be done. What is the reason for this? Why rural women are more susceptible?
Yeah. So if you look at the causes of cervical cancer, so some of the risk factors include poor hygiene, multiple childbirth, multiple sexual partners, so other genital infections. So mainly the rural women might not seek medical care for genital infections. They might just leave it as such, or they might have other problems like exposure to pollutants. So these are some of the risk factors. And the main thing is the virus which is causing cervical cancer is called human papilloma virus, that is usually transmitted by sexual contact. So, and the vaccination is also one thing which is not freely available in rural areas. So that also might be a reason. So mainly it is untreated genital infection, poor genital hygiene, which is common in rural women. That is the reason for high risk in rural women.
Another point to add is the early marriage among the rural population. So their sexual activity starts at a very early age. So that also plays a role in development.
So there's this general fear about cancer always kills. People are not sure about how their lifespan increases or the quality of life is after you're diagnosed with cancer. So there are very specific questions about, like, Anna Lakshmi wants to know what are the causes for pancreatic cancer and if it is treatable and what is the aftermath.
The most common cause will be smoking and alcoholism. So alcohol is one of the most common cause for pancreatic cancers.
Diabetes is one other risk factor, and yeah, just to add to that.
Another participant is requesting for a little more detail on immune therapy and how it really helps cancer patients.
So immunotherapy is upcoming. Right now we have a lot of almost 4 or 5 immunotherapy drugs available, and we use for almost most of the cancers in advanced stages for controlling the disease. So they just activate the immune system against the cancer cells, and they lead to some good responses in immunotherapy. So it is not for everyone. So we do certain tests, and it is only for certain stages of the disease. That is mainly in the advanced stage of the disease. So early stage also it is coming up, but it's still a lot of trials are coming. It's an upcoming field to say. Immunotherapy is upcoming field. Right now we have immunotherapy drugs, and we use it for advanced stages of the disease.
Somebody wants to know that how do we know we have a malignant tumor in our body, and is biopsy the only way, is the only diagnostic procedure?
Yeah, generally speaking, it's a very generic question. Generally, what we advise to the general public is that, as Dr. Rajkumar correctly pointed out, if there is any abnormality in your lifestyle, in your day-to-day lifestyle, as you notice a lump somewhere in the breast or somewhere in the body, and that lump has been there for more than 3 weeks, or you see an alteration in your routine life, like you tend to see blood in your stools, you urinate with some blood in the urine, or anything that is abnormal and that is there persistently for more than 3 weeks, then that is a warning sign that you could be harboring a cancer. So like for example, if you have a sudden weight loss, you notice an ulcer in the mouth, or you see that your dietary, you get a lot of acidity and your indigestion problem is there prolonged for a long time, then these are all pointers that you might have cancer, not necessary that you definitely have cancer. So if you have any of these abnormal symptoms for more than 3 weeks, then we recommend these patients to at least consult a family physician or an oncologist to get themselves screened. So for a general question, we usually advise them to take 3 weeks as the cutoff, and if you have a lump or any of these bleeding symptoms or weight loss or indigestion or anything more than 3 weeks, then better take medical advice to rule out malignancy.
Dr. Satish, I also recall your backroom discussion, because when many times the symptoms are overlapping also, and one is delay in going to a doctor, one is delay in diagnosing causes. So you were mentioning about a multidisciplinary approach, which is very important in treating cancer because it's not a singular disease. Could you just elaborate on that for the benefit?
One of the most common problems that all of us as oncologists face is that patients are unaware and ignorant that cancer cannot be treated with a single medicine. It's not like one pill that cures all. Cancer cannot be treated that way. As I said earlier, the same cancer, let's say breast cancer, in one person may not behave the same way it behaves in another person. In one person, it might be very indolent. In another person, it might be very aggressive and it can metastasize faster. So cancer treatment is usually done by a team of doctors, a team of surgeon, physician, and a radiation oncologist. All the three, usually we sit together, discuss the patient, discuss the treatment plan. We devise a treatment plan based on the patient's history and examination and investigation findings. We stage the patient first, and then we discuss what is the best treatment for that particular patient. So it's not like if one person has breast cancer and the other person has breast cancer, one gets surgery and chemo and not radiation, while the other gets only surgery. These patients come often and ask us, why is that patient gets only surgery and I am getting surgery, chemo and radiation? So the answer is that every cancer is unique, and every cancer in every person is unique. It behaves differently. There are a lot of factors that we consider: molecular signature, staging, grading, etc., to decide on what is the right treatment for the patient. So the patient, what he or she should do is to consult a hospital with preferably a multidisciplinary team which handles cancer. In that way, the patient can be assured that he or she gets the best possible treatment for that particular ailment.
What about the financial burden of cancer treatment and post-surgery or post-treatment maintenance? Do you think that is also a deterrent?
Certainly, finance is a deterrent. Financial aspect is a deterrent. But then, in the long run, these patients should think that they should get cured of the disease. And so, cancer is a deadly disease, and mostly most of the oncologists discuss in detail with the patients as well as the family about the financial implications of the diagnosis of cancer, and whether is it worth spending a lot of money in treating the particular patient. For example, if it's a metastatic pancreatic cancer, then we might not be very positive about the outcome of the disease, and in that case this patient can take a call whether to spend a lot of money. And I'm just giving an example, like if it's an early breast cancer or a locally advanced breast cancer, then there is it is worth spending money for treating such a cancer, because we have seen a lot of patients getting cured of early or even locally advanced breast cancer and lead a healthy, normal life. So usually all the oncologists discuss in detail at the first visit about whether it is actually fruitful spending a lot of money or not.
So can we say that, yeah, certain kinds of cancers are totally curable? Because many times what happens, patient might go into a long remission, but then cancer does tend to come back in a more aggressive form. So what do we tell our patients? Because somebody is also asking that after being diagnosed with breast cancer, can it again recur? I mean, after being diagnosed and treated, can it again recur?
Yeah, it can recur. So that's why we put the patient on regular follow-up schedules every 3 monthly for first 2 years, and every 6 monthly after 2 years till 5 years of 5 years of diagnosis. We keep following the patient. So it can recur. So we keep them under follow-up.
And what is the stem cell transplantation for tumor treatment? Is it working well in our country?
Which transplant?
Stem cell transplantation.
Yeah, stem cell transplant is an acceptable procedure, and it is an available procedure. We use it only for certain indications, mainly like lymphomas and leukemias. It is not for every cancer.
Mm-hmm. Okay, I think we are also running out of time. Like one last question I'll take is on vaccines. Like if any one of you could brief a little more on what kind of vaccines is advisable or from what age, and what is the awareness level about vaccines to either prevent or treat cancer?
Vaccines for the cervical cancer is one of the important cancer. It has high incidence, so it's available as multiple brands are available. One is the non-avalent vaccine. It covers 9 HPV variants. So it will be given in the age group of 11 to 14-year girls. So it will be 2 doses. Today, if you are given, after 6 months, another dose is given. If we after 14 years means 3 doses will be required, 0, 2, and 6 months. So 3 doses will be required for HPV. And boys also can get to prevent other, as we discussed, male genital tumors and to prevent infection. Other is hepatitis B vaccine is available. It already incorporated into the immunization schedule. It will prevent the liver cirrhosis and hepatocellular carcinoma in the future.
Since we are having this discussion on the eve of World Cancer Day, and I would just like a quick 1-minute wrap up from each of you. Like, what would your message be to all your patients, or not just patients, even normal individuals, since cancer is such a feared disease?
So this year's theme is a prevention of cancer. So the most important thing which we can prevent, which one we can do to prevent cancer is quitting smoking if somebody is a smoker. So first is smoking, second is alcohol. Completely avoiding it greatly reduces the burden of cancers. And also exercising every day, at least 20 minutes of exercise is also shown to reduce the risk of cancer.
Thank you. Dr. Rajkumar, would you like to go next?
Another point is that if the patient develops any small symptom, they should not ignore. Many patients ignore that it is considered benign and they are coming at the later stage. That should be taken care and they should seek the medical advice at the end. So this is actually going into the metastatic stage or advanced stage.
Yeah, Dr. Satish.
I'd like to highlight upon just 2 points. One is like there are 2 aspects to prevention of cancer. One is preventing cancer by changing from within and by changing the environment. Like by changing from within, I mean one's own lifestyle. From starting from the healthy diet with fruits, vegetables, and whole grains, with physical activity and trying to shed weight and trying to avoid obesity. Those things can come from within by changing oneself, one's own lifestyle. And about the environmental factors, whatever is there in the environment that can be a trigger for cancer, like smoking, alcohol, air pollution, water contamination, and all that, that has to be taken care of, so that you need to prevent cancer not only from within, but also by avoiding all the risk factors that are there around you, which can possibly cause cancer. That is point 1. In point 2, as somebody has asked, people frequently ask us, like, why does cancer recur and how do we avoid this recurrence? So that has to be stressed upon in this forum, that when we say cancer is cured, more often we say there is a breast cancer, a surgery is done, chemo is done, radiation is done, and the patient is cured. So when oncologist says the cancer is cured, it means that the patient is disease free. But it does not guarantee that the patient may not get the same cancer recurrence sometime in the future. But that doesn't mean that everybody gets recurrence. So how do we understand that? Is that as much as a treatment and screening for cancer is important, follow-up after treatment is vital and equally important, which most patients tend to ignore. When we say that you are cancer free now and you're all fine and healthy, they think that they are totally, they need not visit the hospital again at all, and they default follow-up. So the message today as a key message is that it is not only that cancer treatment is important, but the follow-up visits that these cancer patients should make to the hospital is very, very vital, because at every follow-up, if we could pick up a recurrence as early as possible, we can still potentially cure the recurrent disease as well and give a long life to these patients.
Thank you so much for that nice summing up. And I really thank you, Dr. Satish, Dr. Rajkumar, and Dr. Suresh Kumar for sparing your valuable time for this webinar on cancer prevention, how far we have reached, brought to you by Kauvery Group of Hospitals under the Hindu Wellness Series. And thank you all the participants for sending in your questions. Thank you once again.
Thank you.